Welcome to the Taylor Method for Pain-Free Living, a podcast that features enlightening conversations with experts in the medical field that helps to improve the health and well-being of those suffering from chronic pain due to injury. Learn from leading authorities the questions you should be asking to experience pain-free living. Hosted by father and son, Dr. Derek Taylor and Dr. Hudson Taylor, and joined by industry professionals in the health field, including doctors of integrative medicine and personal injury attorneys. Enjoy well-rounded and informative conversations to help you get out of pain while achieving optimal wellness. Dr. Derek Taylor and Dr. Hudson Taylor are the doctors of Taylor Chiropractic and Laser Center in Florida and California. Both father and son duo have earned respect and a solid reputation for successfully helping people transform their lives by assisting them to discover the hidden causes of their painful health challenges, leading them to experience the resolution of their problems using the Taylor Method. Tune in each week to learn about the Taylor Method, Dr. Taylor's proprietary technology that looks at the whole person and identifies the root cause of pain while facilitating natural healing and helps to restore the body to optimal wellness without using drug injections or surgery.
Welcome to our show. Our guest today is Dr. Hooman Melamed, and he is a board-certified orthopedic and spine surgeon. Dr. Hooman has an international reputation for helping those having spine and back pain and problems regain active and pain-free lives. Though adept at performing a wide range of state-of-the-art procedures, many of them minimally invasive, he exhausts all non-surgical options before considering surgery. He is a frequent guest on talk, informational, and news programs, including The Doctors, Dr. Oz, Steve Harvey, CBS News, ABC News. Dr. Hooman, it is a pleasure to have you on. We want to just start off the show with this question: what sets you apart from all other spine surgeons, orthopedic surgeons out there, and how would you describe that?
Well, first of all, thank you very, very much for having me. It's a pleasure to be here, and I very much appreciate allowing you to share your platforms. So, I always like to think outside the box. I think we, as physicians, we should never be happy and satisfied with. You always have to think, what else can I do to improve patient care? What else can I do to get better? And you guys seeing the spine business, and you see, I feel too many patients are getting rushed into surgery, big surgeries, unnecessary surgeries, and not so many great outcomes out there. And I think no one is focusing on the patient. And the way I like to look at it is look at the patient as a whole, in an integrative, what I call holistic fashion, because I believe in a whole body treatment, not a spine treatment. And I feel like lifestyle changes, thinking about nutrition. I think nutrition is very critical. Your lifestyle, nutrition, how you work out, it all leads to you having spine problems or recovering from your spine. And I don't feel anybody ever looks at that stuff or pays attention to those things. It's more like, let's do the surgery. And I always tell patients, surgery is never your long-term answer. Yes, I'm going to get you out of pain, but why are we having surgery? What led you to have the surgery? So I think focusing on educating patients with that. And, for the last 4.5 years, a little bit more than that, I don't give narcotics anymore. When I do surgery, I've learned how to do the surgery without narcotics. And also incorporating biportal, what I call biportal, meaning two portal, is like basically using two different portals. Endoscopic spine surgery. I started doing it, the first one in the country, back in April of 2019. And as I'm doing more and more, I think it's going to be a game changer for when it comes to spine surgery and the holistic approach we talked about.
Wow, I love your approach there. I mean, it's exactly our philosophy, looking at the whole person and always thinking outside the box. How can I do things better? How can we improve this and not just do the standard commoditized treatments that are out there? And it sounds like, we looked at your website, it looks like you get probably a lot of cases that have been to conventional orthopedic surgeons that just do the same things that they're taught in school. And one of your things there, you mentioned that you worked on a lot of failed back cases. Can you talk a little bit about that? What are some of the common pitfalls and mistakes that you see patients jumping into when it comes to just jumping into back surgery, and talk about that a little bit. Give us some insight from your perspective.
Yeah, I mean, unfortunately, I hate to say it, but about a third of the surgeries I do, they tend to be revision surgeries, which is not good. I mean, look, everybody has, I myself have had cases haven't gone perfectly well. You have to operate on, but I'm talking about like on a pattern, that keeps happening. And I think too many patients are getting unnecessary, what I call implants, like, fusion cases. They're putting rods and screws or artificial discs, where I think either a much more straightforward surgery or sometimes no surgery is the answer. So that's the biggest thing, getting implant, because once you get implants in, as you guys know, it's pretty irreversible. Once you get those rods and screws in, you can't go back. I've had many patients who've come to me. They're like, I don't want to, take it out. I said, I'm sorry, we can't. I said, all I can do is to now fix it. What was done is not working. Let me go in there and fix it. But we can't undo it. And I think too many patients are getting too many, fusions, too many levels fused. For example, like you look at it, you're like, okay, the patient maybe needed 1 or 2, but they got like 3, 4 levels fused, or artificial disc, or the patient needed a little microscopic surgery, for example. I saw one patient recently, not too long ago, that was told they needed 3-level fusion in their lower back, rods and screws. All I did is 1 level, one side, a little endoscopic decompression. I mean, just look at the difference, and what would have happened to that patient long term. So that is, this is what's going on.
What are some of the long-term consequences of getting a surgery that maybe the orthopedist was too aggressive and they did too many levels? What are some of the long-term effects that you've seen in your practice over the years?
It basically, once you go to a fusion, my father had a fusion done, which was, it was justified. He needed it. Look, the people who need it, they need it. There's nothing you can do about it. But I'm talking about the people who don't need it. What's going to happen is, at some point, depending on how young you are, so anywhere from, depending on your age and what's going on with your lifestyle, anywhere from 5 to 20 years, you're going to end up needing another fusion done, and then once you do that, then you need another fusion, sometimes within the next 3 to 12 years after that, or 15 years, and then on and on. You keep needing more and more fusions, basically. And not to mention, it obviously diminishes further your range of motion and, being able to do things you enjoy. So you have to curtail your lifestyle quite a bit and not do things that you could have possibly be doing had you not had the fusion surgery. Look, if they need it, no problem. Like my father had it, my great aunt had the operation. She was 84. We did a fusion. So yes, if you need the operation, there's no way around it. You should get it. But I'm talking about those who unfortunately end up that they don't really need it.
So Dr. Hooman, for all the failed surgery cases you take on, what would you say your success rate is with that, correcting that?
So I'm very, very selective. If I take on a case, I have to really be convinced that I'm going to make a difference. Like this is like the patient has had 4 surgeries, 5 surgeries. They're coming to me. I don't want to be the one that does the 5th surgery and that now the patient goes somewhere else. The buck has got to stop with me. I need to make sure, can I get the result the patient is looking for? So I put a lot of time and due diligence into it. So for example, these are complicated cases. So I spend usually about an hour with the patient, going over the imaging. And then when everybody leaves the clinic, typically, I like to sit down and go over the films myself when it's all quiet, nobody around, and sit down and think about it again. And to think, am I making the right decision here? Is this really what I think should be done? So I started like really thinking about it, kind of self-criticizing myself. And only at that point, if I think, what, yes, it's a complicated surgery. I need to, for example, do 2 days apart, meaning I did a guy recently, 4 surgeries before 4 or 5. I said, what, this is going to be a 16-hour operation. I'm going to do it 8 hours apart from each other. This is a lot of work. It needs to be done, but I can get the job done. So if I'm convinced that I can get the job done and make a difference for that patient, I will do it. And also, I asked the patient to start focusing on the non-narcotic approach. on the anti-inflammatory diet that I give them. I put them on supplements like fish oil. So start educating the holistic approach. And I think once I think I can do the job, get the patients educated, change their lifestyle, nutrition is very key, and the supplements, then I think my results are usually typically, I tend to have over 90% happy patients.
That's great.
So it really comes down to the thought, the time and the thought that you put into it, and like you said, being your own criticizing your thought process, and really determining, hey, is this a case that I can successfully take on, and then empowering the patient too to make those holistic changes, and then doing a well thought out operation. I seen that in your reviews, how the patients are saying, hey, this doctor really cares. He takes his time with me. And is there anything else that you would say, contributes to your success in that?
It's all about quality, and really take your time, review the imaging studies, because surgery, I think, is very serious. And if you don't, you got to change somebody's life, and you can change somebody's life for the worse if you don't do the right thing. And especially if you rush surgeries, where I feel some surgeons, I've seen with my own eyes how surgeons here sometimes do concurrent surgeries. Patients should be aware that there are surgeons who will run 2 operating rooms or 3 at the same time, going back and forth between them. And that is not right. It's not about the quantity, it's about the quality. And, give new patients enough time, talk to them, let them basically leave the room satisfied, meaning I always ask the patients at the end, is there anything else I can answer? Do you have any other questions for me? I will never let a patient leave the room appointment if they still have questions. I just wait until they continue asking questions until they're satisfied. And as I do my own due diligence to make sure I'm doing the right thing. And then always, by the way, before the surgeries too, I always like to sit down, review the films. I'm not talking like an hour before, 5 minutes before. I'm talking like a day or 2 before, or the weekend before. I like to go through the films, especially complex cases, even a couple of weeks before. Go through them very, very carefully, and to make sure what I'm doing is the correct. And sometimes, I've called a patient and says, I'm reviewing your film. I don't think we should do it this way because I realized this and this.
Wow. Amazing. Doctor, what would you say are the most challenging surgeries to do out of all the different kinds?
God, I mean, the big complex spinal deformity surgeries where the risk goes up, exponentially, where for example, you have to remove a whole vertebrae in order to loosen up the spine to fix the alignments. And those are, highly, highly dangerous, where patients could be a high risk of catastrophic spinal cord injury, and it can happen. So those would be the biggest high risk cases. And also, the endoscopic cases, there's a steep learning curve, to know exactly, you're working through this little tiny hole, to know exactly, you got to know the anatomy, you got to know where the nerves are, because, something you think is a ligament, it could be the nerve, and next thing you know, you've completely lacerated it and game over. So it's like the highly, highly complex spinal deformity where the risk of spinal cord injury, and then you got the ultra minimally invasive endoscopic surgery where, there is such a delicate operation, you could easily injure a nerve, lacerate the nerve and stuff.
Tell us about your approach to scoliosis surgeries in regard. You're talking about deformity and whatnot. Can you tell us about your approach and how it differs from other orthopedic surgeons in regards to doing scoliosis surgery?
I think that the planning is very, very critical in these cases. This is not a case, one level you're fusing, you are basically showing up and just doing it. You are basically doing a multi-level fusion where you're changing somebody's life forever. And it better be the correct operation. It better be done as close to perfection as possible, because you have to make sure you fix their alignment, get them to a normal alignment, because that's what they're going to have to live with for the rest of their life. And my mentor, I remember in residency, which I've took away from him, which I was just talking about, he told me, he said, go and stare at the film for an hour. Just sit down a week or two before, just sit down, just literally stare at the film, just look at the x-ray and just keep staring at it and think in your head all the steps of the operation. Think about plan A, B, C, anything, things that can go wrong. If something goes wrong, what are you going to do? If this goes wrong, what are you going to do? So think about all the things can go wrong, and think about any pitfalls that can happen. And I thought that was one of the best advices I've ever had. And I've taken that advice ever since. And I do it. I sit down, stare. I sometimes 2, 3, 4 hours. I look at the imaging studies, go through CAT scan, detail by detail, anatomy at every level, look at it very carefully. That what at any level, anything can go wrong. Where's the risk here? If the spinal cord can get injured, or spinal cord can go out, where would it be? And then in some cases, I've even gone as far as preparing but believe it or not, a PowerPoint presentation to myself. So I put a PowerPoint presentation to myself to write down the steps of the operation and what things can go wrong. What am I going to do? And I don't have a problem at all reaching out. There are some great spine surgeons, respected scoliosis surgeons around the country. So I don't have a problem reaching out and emailing them and asking them, hey, what do you think about this case? I want to do this. What are your thoughts? Any advice, any questions? So I do that more often than not, actually, asking other spine surgeons' opinions.
That's brilliant. I can see why you're set apart from other orthopedists. I mean, one of the biggest complaints that we get is that he didn't take time to listen to me. I was in and out in 5 minutes, and it was, boom, wham, bam, thank you, ma'am. And so I really appreciate how you take the time to do that. I'm wondering, what do you do when you see a scoliotic deformity, and you're looking at the pelvis, and I don't know if there's a leg length discrepancy, but that pelvis is off balance. And how do you factor that in play when you're looking at the structures below the spine, such as the pelvis, or a leg length discrepancy, or maybe they broke their leg when they were younger, and so the one leg grew faster than the other? How do you work that out?
Well, so that's a very important question, because you got to know, is the pelvic being uneven? Is it because of the spine, or because of the patient being shorter in their legs, right? So because if they're shorter, the pelvic is off, it will give you this false sense that the patient's scoliosis is maybe way worse than what you think. So you have to assess the patient to make sure that the spine is not causing the pelvis to be off. They actually have a leg length. And then it's very easy. You do a shoe lift, if you think, to make it even. And then when you get the x-rays, then you'll know if this is a spine problem or a lower extremity problem.
Mm-hmm. Oh, great.
Dr. Hooman, what's your opinion about injections? Cortisone shots or steroid injections. When's it? What's the time and place for an injection?
So I think injections are definitely worth it. Both my parents had it done. I'm not a big fan of steroids in the joints. We do know now that steroids, in the joints can particularly damage the articular cartilage. So we know it's toxic. We know it causes the death of the cartilage. And I don't recommend injecting steroids at all into any joints at all. Now, when it comes to the epidural space, meaning injecting into the spinal canal, patient, you want to get nerve pain relief, things like that. There was a paper that actually showed that there's no difference between steroids or just putting some marcaine lidocaine in there. They'll have the same effect at 8 weeks out. Now, it depends who you talk to. You talk to some pain management doctors, they're like, absolutely, that paper is was not correct. You need the steroid to get the long-lasting effect. So having said that, whether you use steroids or not, don't use steroids in the joint. If you're going to use it around the nerves, I think a little bit at most is fine. And then see how the patient does. I wouldn't do it for everything. For example, if the patient has severe spinal cord compression in their neck or thoracic spine, I would not do that. That's very dangerous, because you are in a tight spot and you try to put that injection in, you can paralyze somebody, which I've seen happen. But I think for many other things, I think the injections are okay. I always tell the patients this: look, you have nothing to lose by doing an injection. Even if it doesn't work, you have nothing to lose. Try a second one. Now, if the second one doesn't work, forget about it. Don't do it. And I don't like to do it more than 3 maximum in a year time. You don't want to keep doing it at 3 every year, because then you can increase osteoporosis, especially if you use steroids in that area, and you end up causing more scar tissue actually as time goes on.
Mm-hmm.
What is your success with central canal stenosis there, and what do you do for that with your surgeries?
So traditionally, a lot of people do what's called a laminectomy, where they remove the entire arch of the spine. I found that operation to be quite invasive. To me, the ligaments that attach to the spine are very important stabilizers. Why would you disrupt the anatomy? You should preserve as much as anatomy as possible. So if the patient were to need surgery, I would consider doing a little what I call a keyhole laminotomy. I call it the roto-rooter. You just get in there, clean out, and try to do it endoscopically, where you basically bypass all the normal structure, get in there and do a clean out. And typically, a lot of times, I like to go, like, for example, let's say I start on the left side, I like to reach across underneath to the other side without going over the other side, basically disrupting everything else on the other side, the anatomy, to get to it. So I like to reach across to minimize as much as disruption to the soft tissue. And when you preserve as much as anatomy as possible, you minimize the surgery like that. If you can do it endoscopically, I mean, the patient's recovery is unbelievable.
It's like a dentist who, somebody's got a cavity, they don't drill out the entire tooth and then fill it. They minimally drill that area out and then fill it, preserving the natural integrity of the bone. Sounds like that's what you're doing there with the spine as well.
That's a very good analogy. Yeah, I mean, just go after the pathology, and you don't need to destroy 80% of the good anatomy just to get rid of that 20% of the excessive bone spur calcification.
And how long does that relief typically last for? Somebody has a bad case of stenosis, they got pain going down both legs, you do a little roto-rooter job. How long does that last before scar tissue builds up again, or the symptoms start to come back again? Is it a one-time permanent thing, or does it come back every 5 years, 10 years? What's your clinical experience been over the years?
Been in practice now starting my 18 years, and patients have done surgery back 15, 16, 17 years ago. They're still ticking, they're still going strong. So the roto-rooter, if you do a good job, can take maybe, at least from what I heard, I haven't been in practice long enough, but they said maybe 20 to 30 years before it comes back again. Have I seen some cases where it recurred after 10 years? Sure. Or even within 5 to 10 years? Sure. But that's, less than 10%.
Well, that's going to be dependent on the health of the patient too, and their lifestyle, and a lot of other factors that are out of your control, right?
That's part of it too. That's part of it too, because remember, exactly, why did you develop this central stenosis very badly? Of course, there's some genetic component to everything, but we do not know that the majority of what happens to us is our lifestyle. We do know that. The genes are not as important the way we thought they are. They are important, don't get me wrong, but we also learn we have the ability to modify our genes, which is not something I was taught. I was kind of told, this is how it is, this is how you're genetically programmed, which is true, but you can modify them. So you are correct about that. I think people who engage in a holistic lifestyle, it may never come back.
Mm-hmm. Yeah. Good.
So, doctor, overall, and we kind of hit on this earlier, but what would you say that you do better than anyone else? Like, if a patient were to come to you and, how would you, what would you say is like your bread and butter, or what kind of procedure or surgery? What do you do better than anyone else?
I think the most important thing, the patients know they can get as much time with me as possible. Typically, I allocate about 45 minutes to an hour for new patients. And you know what? If it runs over a little bit, then so be it. So the patient gets all the time. In fact, I have a policy in my office. If you're not happy with your appointment, your money back, basically. So that's my guarantee. It's been on for years now. And I try to avoid surgery. I think that a lot of patients get surprised when they come to a surgeon and they see, wow, this guy is trying to convince me not to do surgery instead. And you know what? Believe it or not, I've lost patients because they really wanted the surgery done, and I wasn't convinced they need the surgery, so they went somewhere else because they didn't want to try it in conservative modalities. And I'm sorry, I'm not going to do something that I don't feel comfortable. So, and then as far as the surgery, I try to be the minimalist. Sure, I do the big scoliosis operations, but I try to do the minimum. Can I do the minimum and get away with it? Because I tell the patients, for example, I have a surgery coming up tomorrow. I told the patient, I said, look, you want the definitive result, you will need a two-level fusion. You have to have a two-level fusion to get the best result you're looking for. But we can also try the minimally invasive way with an endoscopically. There's a reasonable chance that it's going to work. And if it works, you just save yourself a two-level fusion and potential fusion down the road. And I also told the patient, even if you were to do a fusion, you still need the rotor-rooter. You still got to get the clean out done. You still have to do all of that done anyway. So if the decompression doesn't work, we'll do the fusion, but at least we don't have to do all of that rotor-rooter work anymore. So, doing an operation that doesn't burn bridges, I think most patients go for it. Like he said, you know what, I'm willing to take a chance. If it doesn't work, I'll come back. So, doing the endoscopically, which most spine surgeons do not do, they push the bigger operations. And I think that's what sets me apart, the endoscopic. And also the scoliosis operations that I do in the adults, I've learned how to do the whole thing from one incision in the back and don't put any cages in or any spacers in the vertebrae from the front or on the side or even from the back. Do everything from the back as basically rods and screws, just align it and do good carpentry to get the alignments and get the fusion done. So that's another thing I do, which most surgeons don't do. They typically like to put cages in at multiple levels through different stages of operations, like go in the front, go on the side, and then bring the patient back again, go in the back. No, I do everything in one day, be done.
Many orthopedic surgeons are doing the bigger surgeries and using the cages and coming in from all different angles. And why is it? Is that what they're taught in school, or is that just the kind of, do they feel like they're going to get better results that way? I mean, can you comment on that in your opinion?
I think, it has to go with your training, right? It has to be with your training, your comfort level. A lot of surgeons don't feel they can get the correction unless they go inside the disc space. They kind of loosen up the disc space, put a cage in at multiple levels. That helps to loosen it up so I can get the better correction. So they don't feel comfortable with that. They don't feel comfortable with the carpentry they do. I think a lot of it is a lot of it has to do with your comfort level, with your training and your expertise on how to get the job done. And I hate to say, just like any other industry, there are some bad apples out there. I feel like in anything, even your profession, you guys know, in anything, whether you're a police officer, healthcare, doesn't matter. You've got people out there who do things because of money, because they know the more they do, the more they get paid. That's just the reality.
Let's see.
Doctor, on the subject of fusions, I have one more question. Would you say that spinal fusion is one of the more, I don't know, more invasive procedures? And what are the pros and cons of a spinal fusion?
So the one thing I wanted to also add when you ask about like why other doctors, I also, up until 2019, prior to the pandemic, literally 2019, from 2005 to 2019, for 14 years, I went every year, or 2004 for almost, 15 plus years. I went every year, at least once a year, if not more, at least once a year. I went either somewhere in the country or outside the United States, go observe another spine surgeon. So I feel like I've been very fortunate to go observe many different great spine surgeons all over the country and the world and learn a little bit from each one of them. So I incorporate a little bit of what I've learned from them into them. So I think that's what allows me to do certain things maybe some other people don't feel comfortable. And to answer your good question about the fusion, the key is, the fusion can be minimally invasive. Like I've done fusion where the patient goes home, same day or 24-hour observation, and they're driving within a week. It's not that it's invasive in the sense you can do it minimally invasive. The question is, it's an irreversible operation when you do it in the lower back. When you do it in the lower back, I mean, that's it. It's done. You are permanently changing the trajectory of that patient's life. For example, everybody knows about Tiger Woods. He had a fusion done. Sure, he needed it. He had to have it done. And look, he won the Masters. but we all know he's going to need another fusion in 10 years from now. That's just how it is. If you needed the operation for sure, do it the right way. Make sure the patient gets a great result. And then, yes, they're going to have a very good life, not too bad, relatively very good for the next, depending on their spine, 5 to 15, 20 years before they need the next level fused.
Mm. No.
But it's got to be for the right reasons. My father had it done. As I said, my great aunt, there was no way around it. They had too much instability. They had to have it done.
Mm-hmm. Mm-hmm. So in a sense, I mean, there comes a time and place when a patient is going to need it, no matter what. And eventually in the future, there may be a chance that they'll need another procedure. But in the meantime, that period of time, just the quality of their life is so drastically affected by who does the fusion and the quality of work done. And if you can do a good quality job, you'll give them a great, essentially a great quality of life for that time.
Yes, if fusion is indicated, and here's what I tell the patients. I said there are three things here you got to do. One, correct diagnosis. Do we have the correct diagnosis? Two, do we have the correct, let's say the patient needs surgery, okay? Correct diagnosis. Is the correct surgery being recommended? And three, how is it being done? Is it being done correctly? Because all these three have to be aligned for the patient to have a very good outcome. So, for example, if the correct diagnosis, correct procedure, but the fusion is not done appropriately, which is what I've seen a lot, that's where I think it's sloppy, because, it's what I always tell the patients, the last 20% of the operation is what takes 80% of the time. And some surgeons don't want to spend that time, that extra time. So they kind of just do it, move on to the next case. And here we are, suboptimal fusion done, doesn't heal, or heals kind of in a not the appropriate alignment. And, it starts this cascade of events, which is worse for the patient. And they may need a revision surgery sooner because, it failed sooner. So that's the key, is do it the right way, do the fusion, take your time, make sure that you give that patient this attention, that all the time it needs, not to say, I got to do this in 3 hours. I need to move on to the next case. I got to do my 5-6 cases that day.
Mm-hmm.
What advice would you give our listeners out there? They're really struggling with a lot of low back pain. They're tottering, do I get back surgery or do I not? What advice would you give them in regards to prevention and how to discern whether or not to get back surgery or not?
I think patients should know 90% of people with your problems don't need any surgery. 90% of people. So there's a good chance, that's pretty good odds, 90%. And a lot of people, got to change your lifestyle. You got to change your ergonomics. I think a lot of people have very terrible ergonomics. When you talk to them, you see a lot of people, for example, are looking down. Now everybody's on their phones, iPad, computers. They're sitting now sitting on their couch, sofa, working kind of in this weird, awkward positions for their spine. So ergonomics is very important, because what you're doing throughout the day, 8-9 hours of working, 7-8-9 hours, if you're in a bad ergonomic position, guess what? You're affecting your spine. So that's one thing, changing lifestyle. Nutrition, I'm a big believer in nutrition. Anti-inflammatory nutrition, meaning avoid foods that cause inflammation. Because if you have an injury in your body, if your back is hurt, you're injured, your body needs all the tool it needs to repair itself. So if you keep eating processed sugar, processed food, lots of dairy, lots of animal protein that is like full of hormone antibiotics, guess what? You keep inflaming your body on the inside and you can't heal yourself. And also, I'm a big believer in supplements. So a lot of patients are not taking enough supplements. Unfortunately, we do not, for example, like people think about like carnivores, like you have lions, leopards, tigers. People wonder, like, they don't need any supplements and they're fine. Yes, because when they eat their food, like the intestine of the animals, and remember what type of animals they eat. They eat like grass hazing animals, like, the buffalo, the giraffe, the zebras, the deers, all these things, they have a very highly nutrition, intestine. So when they eat the raw intestine contents and everything, they're getting all of that vitamins from the intestine. We cook them, as humans, we cook. So when we cook, a lot of the nutrient aspects of it goes away. So that's why you need the supplements. We don't get enough, most patients do not get enough vitamin D, what I call D3 and K2. Everybody focuses on vitamin D or D3. They don't get K2. K2 is very critical because the K2 is what helps to push the calcium inside your bone. Instead of the calcium depositing everywhere. Taking fish oil, taking turmeric. I actually think curcumin, which is the active ingredient in turmeric, ginger, black pepper, a good quality fish oil. These are some of the supplements, and making sure you get a lot of fiber. I try to get at least 40 grams of fiber a day in my diet. And I think if you do all of these, it's a combination of all these that I discussed. And on top of that, trying to do 3 times a week of, core and trunk stability exercises, balance training, some stretching. If you do all of these, then I think, there's a more than 90% chance you're not going to need surgery and you're going to get better. I mean, just start implementing those changes. You may not even have to see a doctor. But I would also tell you, there are warning signs, right? If you have severe shooting pain that is not going away, especially if you're developing numbness or any kind of weakness where, hey, my leg doesn't work, my arm is weak, or I'm getting numb, or my balance is off, my coordination is off, I feel clumsy, I have burning in my hands. Those are obviously signs you got to get treated. You got to get seen right away, because some things, if you don't treat them right away, it can become irreversible. But most people don't have that. Most people have just, hey, my back hurts, from I lifted something, or, just started hurting. And also I would tell patients, at 6 weeks, if you're not improving, you got to see a physician. Why? Just God forbid, just to make sure you don't have cancer.
Mm-hmm. And just also doctor, from a chiropractic perspective, typically we see the ones who are in the most pain, or who have the more severe condition. Typically those are the patients that never did anything that you said in regards to quality nutrition, vitamin K2, regular chiropractic care as far as just optimizing the health of the joint, optimizing the alignment, regular exercising. Those who haven't made those daily lifestyle choices are typically the ones that suffer the most. But thankfully, for those who are in need of help, having someone like yourself, someone who will do a quality, as non-invasive job as possible, that's definitely the go-to there. But from a chiropractic perspective, if we can educate the patients on just optimizing the body so that they can avoid, the severe pain in the future, or minimize the risk of that, or even if they have to have a procedure, typically, I'm sure you find that those who prioritize their bodies through nutrition, through exercise, through chiropractic care, probably better surgical outcomes, I imagine, because they already have that mindset.
Oh, 1,000%. That's why I don't give narcotics. When I get the patients on this whole holistic lifestyle, the patients are shocked that their pain is bad after the surgery. They're completely blown away. They can't believe, they're very skeptical going into it, because they heard, oh my God, my friend had to have this. They're like, I had a patient recently say, doctor, I know you keep telling me, but I know it's impossible. I just need the narcotic. I said, look, let's just do the surgery. I'm not gonna not give it to you if you need it. Okay, if you need it, I'm not gonna let you hanging like that. But let's just see how you do. Just going to it. I have it available. I can give it to you. No problem. And he was blown away how he didn't need it. He couldn't believe it.
Wow.
It's called optimizing yourself for the operation. Optimizing.
That's great. Well, it sounds like that's what you do a lot. I mean, it's been a pleasure talking with you today. Are there any closing comments that you want to add or share that you maybe you'd like to comment on as we close our show here?
I think most patients will get better without surgery. Get other opinions. Ask your surgeon as many questions as you want. You shouldn't feel rushed in any appointment. Take whatever. Ask for other opinions. And always look. I'm not saying decompression is always the best approach. But sometimes, if there's a chance it can work, why not try it? Because if it works, you can get away with it, and you don't need the bigger, like the fusion or the artificial disc done. And you always have to think yourself, am I willing to have potentially 2 surgeries done if the decompression doesn't work. And you know what? Some patients are like, no, I want the fusion done. But you got to explain to them. Make sure your surgeon explains to you the ramifications, what potentially can happen, the pitfalls. But sometimes there's no choice about it. Just get opinions, and you feel comfortable, do your research.
Great.
Excellent, doctor. Well, it's been so awesome and so interesting to speak with you. And how can people reach out to you? What's your best way of contact?
They can go on my website, thespinepro.com, or they can email us info at thespinepro.com, or they can call us 424 area code 21 spine. 424 area code 21 spine.
Got it. 424-21 spine. Excellent. Well, you have been listening to the Taylor Method for Pain-Free Living with Dr. Hooman Melamed and Dr. Derek Taylor and Dr. Hudson Taylor, myself. Thank you so much for joining us today. Have a great day.
Thank you very much, Ed.
Thank you for listening to the Taylor Method for Pain-Free Living podcast. For more information about the Taylor Method and how you can find lasting pain relief, visit www.drderektaylor.com. That's www.drderektaylor.com.